All right. Hello, everyone, and welcome back to another episode of PulmPEEPs. We've got a good rapid fire journal club for you here today with a new voice on the podcast. Today, we're going to be talking about the Andromeda-SHOCK trial that was published in JAMA 2019. I'm very excited to have this brought to us by Jose Meade, who's a resident at Boston Medical Center and will be applying to pulmonary and critical care fellowships next year. So, for all the program directors and folks listening, keep an eye out for his application. Jose, thanks for joining.
Thank you, Luke. No, I'm really excited to be here with PulmPEEPs talking about this very interesting trial, Andromeda-SHOCK.
Yeah. So, Jose, why don't you tell us a little bit about what's the relevant kind of background information? What do we need to know to put this trial into context?
Yes, of course. I think this trial is one of the most significant trials published in the last couple of years that inform practice in the ICU and even in the hospital regular floor. And this is talking about early resuscitation in patients with septic shock. And we know that we should be monitoring these patients, but we don't know what is the best strategy for monitorization. And based in the Surviving Sepsis campaign, we use zero lactate measurements. However, we know that lactate levels can be elevated due to other things not related to hemodynamics. And also, we know that the clearance from lactate could be delayed due to multiple reasons. And we also know that capillary ratio time offers a simple, cost effective, universally available, and immediate assessment of the status of peripheral perfusion that can respond quickly to changes in resuscitation.
Yeah, thanks. I think that's a great summary. It's that kind of eternal question of how best to resuscitate folks in septic shock and what are the endpoints we should be paying attention to. And so, Jose, what was the kind of goal or the objective of the trial here?
Yeah, so the main aim was actually to determine whether peripheral perfusion targeted resuscitation strategy during early septic shock is more effective than a lactate level targeted resuscitation strategy.
I love it. And so, tell us a little bit more about the study design.
Of course, this was a multi-center, open-label, randomized, controlled clinical trial conducted in 28 hospitals across 5 South American countries. This was based actually in Chile. For them, the primary outcome was all-cause mortality at 28 days, and they also had some key secondary outcomes, which included 90-day mortality, ICU length of stay, hospital length of stay, and a number of organ support free days, such as free days from renal replacement therapy or from the ventilator.
Perfect. I think those are all great outcomes that we really like to pay attention to, and a lot of kind of patient centered outcomes there too about the number of organ support free days. And so, who was in the trial? Who did they include? What were the exclusion criteria? How would you describe this patient population?
Yes, so they included basically consecutive patients, all of them adults, with the diagnosis of septic shock. This is defined by the third consensus of sepsis and septic shock. And this was defined by suspected or confirmed infection plus a lactate of at least two, and a pressure requirement to maintain a MAP of at least 65. And this after an adequate fluid resuscitation, which was defined as at least 20 cc's per kick over 60 minutes. And I think it's important to say that they excluded patients with other major causes of hemodynamic instability, such as major active bleeding. They also excluded patients with severe ARDS. They excluded patients with DNR status and also patients with some other diagnoses, such as cirrhosis or hematological malignancies, or patients who had a delay in being enrolled in the trial with 4 or more hours after meeting criteria for septic shock.
Yeah, I think that's great. Thank you for walking us through the inclusion and exclusion criteria there. I think it sounds like what they were getting at is really trying to drill in on this early septic shock period and trying to think about comorbidities or other conditions that could confound your volume management.
I think the main reason for excluding those patients were also trying to exclude other drivers for an increased mortality, since other things such as severe ARDS might also confound the results for in terms of mortality.
Yeah, that definitely would be unfortunate to have a trial that wasn't significant just because everybody died from some other thing you didn't exclude. Okay, and
100%.
so maybe taking a step back, one way that I like to think about trials and whether they apply to my patients is to try to summarize who the people that were actually in the trial were. If you had to put this into just a couple sentences, how would you describe the patient population? And if you're thinking about that like table one.
Of course, I would say in summary, we included patients, adults with septic shock by any type of infection admitted to the ICU with other serious medical conditions such as bleeding or ARDS.
Perfect. Yeah. And I think it's worth highlighting that this was a pretty sick group of people. The mean norepi dose at enrollment was 0.24 mics per kg and 0.20 mics per kg in the two groups. The mean lactate at enrollment was about 4.5 between the two arms, and only 25% of them had a normal cap refill time at enrollment. And most of those infections, because we know sometimes sepsis from different etiologies, different types of infections can behave differently. Most of the folks in this trial had either an intra abdominal source or a pneumonia as the source of their sepsis.
Now I can talk about what were the actual interventions in the groups or the arms of this trial. So what they did is they had 424 participants that were randomized on a 1-to-1 ratio into an 8-hour-long resuscitation protocol guided by either capillary fill time or lactate serial measurements. So for the peripheral perfusion groups, they measure the capillary refill time, applying firm pressure to the ventral surface of the right index finger. What they did is that they apply actually a glass microscope slide, maintaining pressure for at least 10 seconds, and then they retire the slide and with a stopwatch measure the time that it take for the color of the capillaries to come back normal. And I think this is a great point, as opposed as many people used to do it before, which was like applying pressure to the nail fold. And this is actually like just the other side of the finger where they are applying pressure. In the other side, for the lactic group, they just basically measure lactic levels every 2 hours with the goal of normalization or decrease of the lactic levels by 20% every 2 hours.
Perfect. Yeah. And I think it's a great point that they standardized and described so explicitly the way that they assessed capillary refill time. If anytime a key part of your trial is a physical exam maneuver, it's important to make sure everybody is trained in that and that we're all talking about the same thing. And so, just to be explicit too, that they labeled a refill time of greater than 3 seconds as abnormal. And then you mentioned how they check the lactate levels every 2 hours. They reevaluated folks' cap refill every 30 minutes until they were normal. And then can you talk a little bit about what the goals of the two monitoring arms in these groups were?
Basically, what they were doing is the strategy for resuscitation will be virtually the same in the both groups, meaning if their parameter will be abnormal, they will continue giving crystalloids every 30 minutes. And the ultimate goal will be normalization of the lactate and normalization of the capillary refill time. Then they were also measuring other parameters such as central venous pressure to make sure that they were not over resuscitating the patients with IV fluids.
Perfect. Yeah. So that those goals of making the cap refill normal, again, that kind of 3 second cutoff, or in the lactate arm, either normalizing the lactate or having it decrease by 1/5 in that kind of 2 hour interval. Because you can imagine if someone's lactate was like 20, it might be hard to make that normal in 2 hours. Cool. Okay. And so we've talked a little bit about how this is a trial that is looking at early resuscitation and sepsis. Can you talk a little bit about the actual resuscitation protocol that they used?
Yes, of course. So what they did was base their resuscitation strategy on fluid challenges of 500 cc's every 30 minutes until they achieve the goal for either arm. And as I mentioned before, central venous pressure safety limit was reached, or if the patient became fluid unresponsive, then they will stop with resuscitation. And if it wasn't enough and the patient is chronically hypertensive, they use a trial map of 80 to 85 with pressors and then return back to 65 if they wasn't unsuccessful in meeting capillary fill time or lactate goal. And then what they did is, if after all these interventions, if the patients will not still be under goal, then they will use a fixed dose of the butamine or Milron on top of the use of the initial pressure strategy, such as norepinephrine.
Yeah, thank you for walking us through that. It sounds like I had those three arms, the fluid challenges until someone was not fluid responsive anymore, where they hit safety thresholds. And if that didn't work, they tried raising the MAP. And if that didn't work, they tried some inodilators. I think folks may have some quibbles with that particular approach to resuscitation that may or may not reflect every person listening's individual practice. But I do think it's really nice that they were so explicit about and standardized about the way that they approached this.
I agree. And that being said, I think at the end of the day, what we do in clinical practice is not to follow only one parameter for guiding resuscitation strategy in patients with septic shock. I think oftentimes we take several different parameters along time and we guide our decisions based on multiple parameters. But as you mentioned, this is at the end of the day a RCT that is trying to understand which one of these two parameters is the best for our patients.
Yeah, perfect. And then one thing I think that's also worth emphasizing here, a little nuance, is that this is not a trial of different interventions, right? Everybody got the same resuscitation protocol. And so it's a trial of different monitoring strategies, like endpoints of that resuscitation, and not necessarily the resuscitation itself, which I think is a helpful way to try to frame how to interpret some of this.
Exactly. And this great point that you're highlighting, it's actually seen in the fact that both groups were managed in an identical fashion, which means the way that they were being treated was the same, just what was guiding the resuscitation was the thing that was different. But in terms of interventions, they were receiving the exact same sort of interventions. I think this is essential also for the validity of the study and like cleaning up any other noise that will be in our results for the outcomes.
Yeah, I love it. Okay. And so we've talked a fair amount about what they were looking for, who was in the trial, and what they did. Jose, what did they find?
So the main thing about this trial, they actually found in their main outcome of 28-day mortality, they found an 8.5% difference in favor of the group of capillary refill time. Nonetheless, this was unfortunately not a statistically significant difference.
Yeah, I think this is I feel like a quintessential ICU trial result, right? Where there's an interesting point estimate that may or may not be statistically significant, but it's close to it. Whenever something like that happens, I wonder about power. And in this case, too, I do have some wonders about whether this was an underpowered trial. There were 424 participants, and when they did their power calculation, they estimated that 420 patients would give them a 90% power to detect a reduction in mortality. But importantly, that estimated effect that they were building their study around was a 15% reduction in mortality. And whether, again, since this is not a trial of different interventions, it's a trial of a monitoring strategy and an endpoint of resuscitation, I think you could maybe quibble a little bit with or wonder whether this was just underpowered. And if they'd had another couple hundred patients, it's possible that they might have found something here, but we don't know. And so it's a provocative result for sure.
Absolutely. I feel like 8.5% mortality difference in the ICU. It sounds like a very clinically significant result, but unfortunately, this was a non-statistically significant result. That being said, again, this was not an intervention RCT, but a strategy for monitorization of patients. So that might also influence the non-significant statistical difference.
Perfect. Yeah. And sometimes it can be helpful when the headline result is like this to look at some of those key secondary outcomes. What did they find when we take a look at some of those other outcomes of interest?
Yeah, so in terms of organ support 3 days, there was not a difference, though organ dysfunction at 72 hours measured by the SOFA score seemed to have a statistically significant difference in favor of the capillary refill time group.
Perfect. Okay. Thank you. So that is interesting. No frank change in organ support, but maybe a little bit less organ dysfunction. Okay. And whenever there's a trial, we've talked a little bit about maybe some of the limitations, but I always like to try to be explicit about these. Jose, are there any other things that you think we should keep in mind when we're trying to interpret how to apply this to our practice?
100%. I think acknowledging limitations first, it's unclear whether the intervention is the optimal way to resuscitate patients, since as we mentioned already, we in clinical practice often do multiple things for monitorization of these patients. And then again, this protocol designed to essentially titrate IV fluids to normalize perfusion. And oftentimes we're doing multiple other interventions that it's not only centered in the administration of IV fluids or the administration of pressors. And then in the other hand, there's also the possibility that capillary refill time was better just because of people triggered interventions less. And as we know, it normalizes quicker. So the whole idea here is that if we follow the capillary refill time, we're less tend to give IV fluids, less tend to give pressors that we know that when we do a little bit too much of that, that also impacts in the outcomes of the patients.
Yeah, I think those are great points. The first, that it's really great that they had this standardized approach to resuscitation. It's not clear to me that's necessarily the optimal way to resuscitate people. It's not clear to me that giving fluids until someone stops being fluid responsive is ultimately the best thing for everybody. There's this whole concept now of fluid tolerance, and I think we're recognizing more and more some of the potential downsides of fluid administration in excess. And so that is always a good nugget to think about. And then you're right. A big difference between the monitoring arms is that capillary refill normalizes quicker than lactate, right? They were checking it every 30 minutes, lactate every 2 hours. And so it could just be that if the intervention, the resuscitation was suboptimal, or just we're doing things that don't help people, then maybe all the benefit of cap refill is just that it leads us to do less, which, to be fair, is a valid thing. Less fluids, less epi, and less pressors in that cap refill arm is potentially a real argument in favor of it. If there's no difference in mortality and we get to do a lot less interventions, you could argue that is a good thing. And then the
I
last thing I would
completely
mention too is just on the topic of the cap refill time is that they didn't evaluate the inter-rater reliability. And so I do wonder sometimes whether there may have been some subtle differences, though the technique was pretty standardized. And I would hope that it's not too difficult. People don't disagree too much on when the color of somebody's skin kind of returns back to normal. Hopefully that's not something that's got too much variation.
And I think that's a great point. I think that's been the main pitfall of capillary full time until actually this trial came up. We will not agreeing what is the best way. We will not know what is the clear cut threshold. So I think this trial is also validating this for further studies and for the implementation of this into clinical practice.
I love it. Yeah. And so, Jose, if you had to describe in summary, what is your takeaway from Andromeda Shock? What are you going to take with you going forward, having reviewed this paper with us now?
Look, I think after reviewing all of this, I would say that the standardized capillary full time, it's a free, widely available, safe tool that maybe it's comparable to lactate for patients with sepsis and septic shock. That might be just one more tool in our toolbox as clinicians in the ICU. And I would say for me, as an internal medicine resident, it's useful not only during my ICU rotations, but also on the wards where many times patients are actually in the regular floor and they start having early sepsis, septic shock. And sometimes in the meantime, I'm waiting for a lactate. I could start taking some decisions based on capillary ritual time.
Yeah, I love it. Anything that brings us back to the bedside, I feel like I'm a little biased towards. Critical care is a contact sport. Awesome. And then I think too, it's worth mentioning there is a follow up study planned, Andromeda Shock 2, which is an international trial with some centers in Europe and then also in the US participating. Watch this space. There should be more to come in the future.
Absolutely. It's going to be exciting to see what this trial shows with more patients, more interventions, and just trying to understand what is the best for understanding the hemodynamics of our patients.
Perfect. Awesome. Thanks again, Jose, for bringing this to us. It's been great working with you. I think done a wonderful job of reviewing this pretty thought provoking paper. That's going to be a wrap for us today. I hope you all enjoyed this. Give us and follow us wherever you get your podcast, and we'll see you guys next time.
See you. Thank you, Luke. Thank you, PulmPEEPs.